Thank you very much. Let me turn it to Jackie Ward, who can talk to you about how the question and answer session will go.
Thanks, Walter. So we have solicited questions through the registration page and have gotten a lot of questions already. So I can't guarantee we're going to get through them all, but at this time, we're also going to turn on the chat so that you can pose questions in the chat box, and everyone should be able to reply, to put in the chat using all panelists and attendees so that everyone can sort of see their responses or questions, and it can be more conversational. So to kick us off, I'm going to pose a question that we got from the registration page. And I'm also going to briefly address a new introduction, which is Dr. Avi Nath, who is the clinical director at the National Institute of Neurological Disorders and Stroke, and he is an expert in this space. So we may also be directing some questions his way. Hi, Avi. And I think this first one I will kick your way, Avi, which is which brain cell types are most vulnerable to SARS-CoV-2 infection rather than related inflammation? And are there specific signs and symptoms that can be traced to these infected cells? Oh, and just real quickly before you get started, is that we're envisioning this as more conversational in tone. So if there are other NIH participants who'd like to respond to that, feel free to jump in when Avi's finished. Thanks.
Yeah, thanks. So that is an important question. If you take cells in vitro and try to infect them, then you can infect the endothelial cells quite easily. And the second thing you can infect are the astrocytes. However, in order for the virus to get to within the brain, there has to be viremia. And there is no viremia that occurs in these patients, very, very rarely. So even though cells in the brain could potentially be vulnerable, when we looked at the brain, we didn't find anything. And we looked very extensively. These patients had died suddenly from COVID, so in the acute phase of the infection. We did extensive PCR analysis, RNA-seq analysis, immunostaining, in situ hybridization. And so if there is any virus, it's very, very small amounts. And as Walter had mentioned, the German groups described something, but if you look at those viral copy numbers, they're extremely low. And by immunostaining, they found 1 or 2 cells. And actually the cellular morphology doesn't even look like a cell. And where they found increased immunostaining, they didn't find any PCR. Where they found PCR positive, they didn't find immunostaining. So my guess is the virus is not really neurotrophic. And so as opposed to rabies and polio, we find lots of virus in the brain. Patients with SSPE, which is due to measles, the brain is loaded with virus. So this is not a neurotrophic virus. I think most of the effects that you see here are really secondary to other indirect mediated effects in the brain.
Allison, I'm going to direct this one your way, which is what do we know about the effects on pregnant and pediatric populations? And I'll also combine that. I'm not sure if you'll be the right person to answer this with a question that just showed up in the chat about are there sex differences and neurocognitive implications of COVID?
So great question. So what do we know about pregnancy? Numbers of groups have come out with publications, and there's one that will be coming out from our maternal fetal medicine units very soon. We launched a study there as well to look at a very large number of pregnancies during the initial period of the pandemic. What we know so far is that women who are pregnant do not seem to have, by definition, more severe disease, and those that do have the presentation of more severe disease do tend to have more complications and increased risk for mortality, especially if it's at time of delivery. We are starting to track that there are studies looking at preterm complications, including, increased presentation of preeclampsia or hypertensive conditions which may be associated with some of the inflammatory responses that have been discussed. With respect to children, we know that about 2 million children have been diagnosed as COVID-19 positive, and we know that many of them can be asymptomatic. What we are learning now is that some of those children who are asymptomatic may have longer term cardiovascular or pulmonary issues, even if they do not have the disease. If they do have the disease, they are also at risk for post-acute COVID syndrome sequelae, so they can have some of the same sequelae that were described by Walter earlier. And then the only other thing to discuss is that we are not seeing, as Nora mentioned, increased vertical transmission of this virus. What's still up in the air is the antibody transmission, meaning the babies do not seem to have antibodies from their mothers if they are COVID-19 positive. What's unclear to us, and we are also studying, is if there is breast milk transmission of antibody. That also does not seem to be the case. And we also need to understand, as women are getting vaccinated, because that was part of the EUA, was that pregnant women could opt in to the vaccination, though there were no real clinical trial data for that. Whether there are going to be impacts of the vaccine and antibody transmission from vaccine, that is also not known, and something that we are thinking about studying in the coming weeks. So I think we do have a lot more work to do, and also recognizing that the first trimester babies are really now, obviously we have a time lag, right? In that we are just now seeing some of the babies whose mothers may have been infected in the first trimester. So you have a natural lag in terms of your ability to study those outcomes. So I think we will have more to come on this. And we have multiple articles and press releases available for people if they need on our website.
And I just want to add that the reason why I presented the data in terms of the Spanish flu with schizophrenia is that the manifestation of the disease did not occur until the second decade of life of these children, which is in the teen years that you start to see the manifestations. So again, highlighting the importance of having follow-up of these children that may look normal in order to be able to determine if indeed they are potential long-term complications, as have been seen for other viral infections. And again, I highlight again, this was not associated with the virus itself. It was associated with the immune inflammatory responses during the pregnancy status. And now that we have brain imaging technologies, which can be used to periodically image these children, we may be in a better position if indeed they are happening to detect them early on so we can intervene.
Agreed, Nora.
Thanks, Allison and Nora. There was a question in the chat about fMRIs between patients who have recovered from COVID-19 compared to images that they had before coming in contact with the virus. And this sort of echoes one of the questions we got on the registration page, which are there brain MRI features associated with SARS-CoV-2? So Avi, I'm gonna potentially tag you for that one, but Nora or others who may have expertise there, feel free to jump in.
So in general, if you don't have any neurological symptoms, the MRI is usually normal. However, there are patients that have been described with neurological symptoms. And there, when you do the MRI scan, you can find a variety of different changes. You can find punctate white matter lesions scattered throughout the brain. You can find diffuse white matter lesions in the brain as well. And then there are some other rare conditions like acute disseminated encephalomyelitis, where you can find patchy enhancing lesions throughout the brain. And yet another condition called acute hemorrhagic encephalopathy, where you find bleeding in the brain, just microhemorrhages, most often in the thalami on both sides. And then you can find it in other places too. They're usually bilaterally symmetrical types of lesions. Now, we did MRI scanning on autopsy tissues where these patients did not have any known neurological symptoms, but we used a very high resolution MRI scanner. And there we did find lesions in the brain, but these are very small and they could actually be missed by regular MRI scanning. And there we found two types. One is these small inflammatory lesions, and the second is these small microhemorrhages in the brain.
I thought that also, and absolutely, I mean, we know that it's likely that a lot of the pathology is going to be related almost vascular and immune, and therefore the white matter abnormalities, the evidence of small vascular disease, and in sort of edema-like, maybe some of the things that we're observing. Though I thought that the question that was posed was, has anybody done studies with the fMRI functional activation before and after COVID? And nothing jumps on my brain that this has been done, but Abby, you may know better. But what does jump into my brain, if there is, if COVID is interfering with blood vessels and the ball signal, it requires proper vascular reactivity on the one hand, as well as proper oxygenation, one could observe that this in and of itself may produce a modified bold activation signal, but again, more related to the oxygenation and the vascular reactivity. But I'm not aware of anybody that has published anything on this domain. But do you know anything, Avi? Has anyone published on this?
No, I don't think so. But I think your point is well taken, and that's an important study that somebody should do, because these patients do complain of various kinds of symptoms, particularly dysautonomia, and it's possible there's decreased cerebral blood flow, and the vascular lesions that you described in addition to it. So there are a lot of reasons why we should probably look at bold activity by functional MRI in these patients. I think you make a very important point.
Hopefully some of the longitudinal studies that have repeat imaging are asking about virus infection between scans that may be able to use those studies efficiently.
Yeah, that's good. Yeah, makes sense.
Okay, so I'm going to move on to a couple of questions that are related to taste and smell. So Susan Sullivan, I'm hoping you'll be able to jump in here, and I'll throw them all out and you can answer them in whatever order you'd like, which is, are there interventional strategies for loss of smell and taste? Another question is related to a case of COVID and losing the smell function, but is now suddenly, after recovering, experiencing horrible smells and tastes, and whether that is a known or common effect at all. And then there was a question in the chat box about whether loss of taste and smell is associated with less disease severity. So I'm happy to remind you, since that was a lot at once.
Okay, so I just answered the one in the chat. So there are some reports that smell and taste loss might be associated with less severe disease, but I think it's really too early to know for sure. It's still controversial and needs further study, which we have funded those studies. I would also say to that is it's still undetermined if there's a taste loss, because a lot of these things were self-reports rather than objective testing, and there's a lot of confusion between the notion of flavor, which is the integration of taste and smell, and actual taste. So it could be that these individuals were reporting flavor loss due to smell loss rather than actual taste loss. And the second question was intervention. So right now, if someone loses their sense of smell, there's some idea out there that you can do olfactory training, that is like smelling 4 odors 2 times a day for several months, and that might help improve function. But I think the data on this is pretty sparse right now, and with no real controlled clinical trials. So, it may or may not have any impact. But having said that, since there's no side effects or to olfactory training, it certainly might be worth trying.
So we've received a question prior to the event about particular cognitive differences of effects of SARS-CoV-2 on aged individuals. We'll sort of link to the other question that just came in to the chat about circadian rhythm and the crucial role of that system in older individuals, and whether there are any particular funding opportunities linked to that as it relates to COVID-19.
Yeah, I mean, definitely there is the idea that COVID-19 might be accelerating aging, and there is already some data out there, both from epigenomic studies, but also other markers of aging, suggesting that this might be the case. The NOCI that I mentioned, it's geared toward funding opportunities for aging and Alzheimer's disease and COVID. Now, regarding circadian rhythms, I mean, that's a really interesting question. I don't think that there is a lot of data on this respect, but definitely it's something that we're definitely very interested on receiving applications, particularly as it relates to Alzheimer's disease, circadian rhythms, and COVID-19. Again, the connection between epigenomics, accelerated aging, and circadian clocks is I mean, well known. So it is to be expected that there might be an effect there of SARS-CoV-2. So, and again, you know, you don't have to necessarily apply for these things through a specific NOCI or PAR. I mean, it could be de novo, a new application, R01, R03, R21 through the parent type of awards that we have. So I think these would be very interesting to us.
Let me just add this, Walter, that sleep disorders have been seen fairly commonly in people who are still suffering symptoms of COVID. One doctor actually, in speaking with him, said his patient told him that it seemed as though they forgot how to sleep. So quite dramatic, yeah.
And
Walter.
I can also interject just in this one, because I think it is also important, as we were asking, what are some of the cells that are more sensitive to the virus? The choroid plexus actually has a is the area on the brain, the cells in the brain that have the highest concentration of the ACE receptor needed for the virus for entry. So we can predict that there may be disruption in the production of cerebrospinal fluid, which again occurs at peaks during sleep and is implicated in the lymphatic pathway that is necessary for proper removal of toxins in the brain. So I think that that's another area that is important for us on the neuroscience to do research on, because at this point is more sort of expecting where we are going to be seeing things based on the expression of this receptor.
Thanks, Nora. Walter and Yolanda, who is a member also of the NIH Pain Consortium, I'm going to direct this one to you, which we received prior to the event, what are the consequences of long haul COVID on pain? So Yolanda, yeah.
So thanks, Jackie. So I think, as we know, there are, as Walter mentioned a little earlier, there are reports of pain such as chest pain, headaches, nerve and muscle and joint pain, as well as these existing with other comorbid conditions such as fatigue and sleep disturbances that were just mentioned, and that there are a range of symptoms experienced by some individuals with long COVID, and that the reports indicate that these can be cyclical or variable, but the mechanisms by which these manifest, the relationship to the viral infection, and how long these symptoms may persist is as of yet unknown, and definitely areas of research of interest to us. And there are also emerging reports indicating that, the increased stress and anxiety and other adverse effects on psychosocial status brought on by the pandemic and challenges associated with obtaining care is having an effect on the new onset and intensity of existing chronic pain conditions such as migraine, and orofacial pain conditions such as temporomandibular joint disorders, and the latter is an area of interest for NIDCR. And just one example, an increase in stress can lead to increases in bruxing or tooth grinding during sleep, leading to increases in jaw pain. And there are some reports of worsening of migraine headaches during infection. And I would hand it over to Walter.
Right. So I think there's just so much we don't know. So the effect on the peripheral nervous system is pretty much unexplored at this point. But as Yolanda said, pain is a very common complaint. So I suspect there is something there. It's chest pain, abdominal pain, joint pain, people complaining of tender nodes. You have to be a little careful. People in intensive care units who have been in a very unusual situation on a respirator, they also will have pain that goes on for months after they come out, regardless of COVID. The other peripheral nervous system to think about is the autonomic nervous system as well. There are people who are reporting that they have frequent tachycardia, postural orthostatic tachycardia, sense of feeling hot or feeling cold. So there may also be an affection of the autonomic system.
Nora, I'm going to direct this one to you, which is, are there any thoughts on using ketamine or derivatives of ketamine for treating COVID-related neuroinflammation? There might be others who would want to respond to that one from our panel.
I can respond to that if you
Thanks.
want.
I
So
was going to
ketamine is
say,
really not a great anti-inflammatory drug. If you want to treat inflammation, there are a lot of better ways of doing it. But if you want to treat depression or something, then maybe that's an opportunity there. But only intractable depression, that wouldn't be the first line of treatment. That's the way at least I would look at it.
but I think though, I mean, and I agree completely and 100%, but the another opportunity for ketamine is potentially for pain. And there is evidence that actually ketamine can be quite effective in treatment of pain. And if, as Walter was commenting, there is a higher vulnerability of chronic pain with COVID, this could provide an alternative. But again, there are many drugs that are being tested with wide variety of mechanisms of action, and it is unclear what their effectiveness may be or what their promise may be for treatment of various aspects of COVID-related neurological and psychiatric symptoms.
Walter, yeah, maybe you can address this question in the chat about, or Avi potentially, about dysautonomia, and any thoughts on how that arises, whether it's directly from the virus or from the immune reaction.
So we don't really know. In fact, the symptoms are dysautonomia, but when we looked for a sympathetic dysfunction, at least in the very few patients that we've studied, we haven't really found anything. So our feeling is that maybe this is a vascular problem and not necessarily, because if the blood vessels are not reacting to an intact sympathetic nervous system, you're going to have symptoms that look like dysautonomia, but not necessarily due to direct effects on the sympathetic nervous system. We've looked for autoantibodies to the nicotinic acetylcholine receptor, haven't found any. So I think it remains unknown how that is being mediated, but I think one should keep a broad differential diagnosis for these patients and not be focused on the fact that this may all be just related to a sympathetic dysfunction.
Walter, did you have anything to add there?
No, it's just that I think, yeah, we have to keep an open mind. Clearly, there's the effects of the virus, and then there's the effects of the immune reaction to the virus. So a lot of the real serious acute problems we think are related to the immune reaction, the cytokine storm. There are antibodies that form for sure, and that's why we want to get vaccinated. But clearly, in many infectious conditions or para-infectious conditions, the immune response leads to disability in the nervous system. And I think we just don't know enough, but a reason why we need to investigate more.
And the other point that I wanted to say that I also think why it is, we need more investigation too, is like in the case of cancer where you need more than one insult to observe an effect. So as it was mentioned regarding elderly people, that if you have COVID or you have already early Alzheimer's disease, then the manifestation of pathology may be accelerated. And the same thing may be true for other situations like substance use disorder, where already that drug can produce vascular injury and inflammatory changes, and thus the associated kick from getting COVID may precipitate a presentation that otherwise would not be observed, so that the interaction is required in some instances to manifest the neuropathology of the virus.
Well, I just wanted to chime in and say, let's not forget the chronic stress thrown into the mix, because we know that chronic stress can have effects that are endocrine that are autonomic, and then also it can be have effects on immune responses. So, you know, it should not be, you know, left out of the equation. I think it could be very important here.
Yeah, I mean, especially the people who've been hospitalized, you know, intensive care units for weeks, not being able to see anybody. The doctors are all gowned up and you can't see their faces. And it's like torture. And then people have guilt about, you know, they survived and someone else they know didn't survive. So the anxiety levels in people after COVID is exceedingly high, and depression, as you might imagine.
Yeah, and that's going to cause this chronic sort of amping up of both sympathetic activity, but also it could also cause a chronic immune activation, elevated cytokine levels that have been shown to occur in patients who have chronic stress. So it may add, you know, it may not be the only explanation, but it may be an additional factor, as Nora said, that could compound the other effects.
Elaine, I completely agree, and I'm thankful that you're bringing this up, because the other issue, as we're discussing the issue of what are the effects of COVID, we're also seeing an increase in mortality from other diseases overall, and this may represent exactly what you and Walter are discussing. So the situation of stress provided by COVID then make those individuals more vulnerable for the other medical conditions. So it goes bidirectionally.
Yeah, and let's not forget obesity, because we know that that's a factor as well, and that can also increase inflammation. So, you know, there's probably a lot of factors that can just pile up.